You can still work to find the presentation. I sent it to the gmail.com a few minutes ago. To start with the definition of guideline adaptation, that's important to know. And the ADAPTE group, original ADAPTE group, set a definition in 2006. And it is a systematic approach to considering the use and/or modification of guidelines produced in one cultural and organizational setting for application in another context. That's the definition of guideline adaptation. So the awareness of your context is very basic for the principle and for the process of guideline adaptation, because the one context is not the same as the other. And then there are different levels. We aim to use guidelines because we think it is more efficient to use existing guidelines for your developing your own guidelines. But there are different levels of guideline use. You can adopt the guideline and say, well, this is okay with me. It fits in our context. We do not need to change the language and the format. We adopt it. The second level is that you keep the text, but you change the format with another, other title page, and you still need to recognize the original guideline developer, of course, but that's the second level. The third level is if you have another language, you can translate the guideline. That's the third level. The fourth level is that you adapt the guideline. You keep the evidence and recommendations which are okay, and you can modify recommendations if they do not fit with your context or with your questions. And you include an update of the literature. And the fifth level is that you use the guidelines as a source of a literary review of evidence. We are talking about the fourth level, adaptation of guidelines. Okay. What are the aims of guideline adaptation? Yes, one, you reduce duplication of effort, especially for the systematic review portion of a guideline, because that is very time consuming and you need a lot of people to do that. And we think that you can save time and resources if you compare that with developing guidelines from scratch. That's one of the aims of the guideline adaptation. And also an aim is increasing awareness of contextual factors in guideline development and implementation. You develop a guideline, but you also want to use it in your own context by the professionals and by the patients. So awareness of contextual factors is also very important. And the last aim is that it's also an educative process. It's a learning. You can learn by adaptation of guidelines. You can learn by how existing guidelines have been developed, how they report about the process, how they present their recommendations.
Jaco, can I suggest you share the screen from your side again, because I cannot find them at all in,
yeah.
in my
I can still again try to share the screen. And can you see my slide now?
Yes.
Different forms of guideline adaptation?
Yes.
You can see that? And,
yes.
And when I continue, you can see the next slide, history of ADAPTE collaboration. Yeah. Yes. And when I switch to the presentation mode, you can still see my slide on definition of guideline adaptation.
Now, history of the ADAPTE collaboration. Yes.
You can see my slide on different levels of adaptation.
No, I can see history of the ADAPTE collaboration.
Okay, then you have only the definition now. Which slide do you have now?
History of the ADAPTE collaboration.
Okay, that's okay. So I think it works now. So sorry for it. So I continue with this slide, because you have different levels of guideline adaptation, but also different forms. You can use guidelines within your country and then apply it for your local context. That's particularly true for large countries like Canada, like US and Australia. So you keep you take a guideline from another province and you adapt it to your own province or region or state. And there's also a trans-contextual adaptation of guidelines. You have one country in another continent, for instance, and you use that guideline for your country. That's trans-conceptual adaptation. So that's from a distinct cultural and organizational settings. So you also need to be aware of these two forms of guideline adaptation, and the ADAPTE resource toolkit can be used for both. The history of the ADAPTE collaboration. Well, the first group who published about guideline adaptation in literature was the Practice Guideline Evaluation and Adaptation Cycle in Ontario. That was a research project in the School of Nursing, and they used guidelines, I remember in clinicology, to produce their own guideline. And they evolved the methods and came up with a cycle. I will show you the cycle soon. And the second initiative was in 2003, soon after the publication of the AGREE instrument, with the same people involved, but they got a request from the Quebec Ministry of Health and Social Services to develop guidelines in Quebec. And the French people involved in the AGREE collaboration, together with other people, formed the ADAPTE group.
And can you go back to the regular mode? Maybe now you can change, because the presentation mode does not change. It's static with the history of ADAPTE collaboration. So
okay.
I guess if you go back to the regular mode, it will work. I mean, you can.
Okay.
Sorry for interruption.
Sorry. So I continue share my screen. Is this better now? You can see the history of the ADAPTE collaboration.
Yes. If you can try to move.
Yeah, and now you can see the figure.
Yeah. Okay, this is good. Yeah.
Okay, so the presentation mode does not work. Okay, good to know. Okay, we continue. So these were the two first initiatives on guideline adaptation. And well, interesting, both of them were also in Canada. Yeah. And well, the Quebec government would also ask the Ontario group to help them, but the difference in language was more important than the region. So they asked the French people to help them. And here you can see the cycle of the Ontario group. Do not read it in detail, yeah, but you see you can recognize the steps, also comparing it with guideline development de novo. And here you have the adaptation process. So there's much in common, and you see, well, we are both doing the same, and our aim was to reduce duplication of efforts. So we should mix and we should do it together. So that was the start of the ADAPTE collaboration in 2006. And here you can see the people of the original ADAPTE group, and on the right side, the people of the original Ontario group. And you can see different countries were involved. And Beatrice Ververs was the leader of the group in France, Quebec, and Melissa Brouwers was the leader in the Ontario group. And they were also, both were also involved in the development of the AGREE instrument. So they knew each other very good. And that was very successful to keep our initiatives together and to continue with developing the ADAPTE manual and the ADAPTE process. Well, and what the success of the approach was, it is a systematic approach. And to reduce duplication of effort, okay, that's one thing, but we would like to ensure the quality. So we would not lose quality of the guidelines. And because we learned a lot with developing the AGREE instrument, we still aimed to keep the quality of the guideline, of the adapted guideline, comparing the guideline development de novo. We also would like to encourage confidence in and acceptance of the guidelines by the target users. So we're also focusing on using the guidelines that it was really accepted. And also the promotion of the use by external groups, like government, for instance, or patient groups, is also important. Then this is the adaptive process. You start with a preparation phase. That's similar when you start guideline development de novo. I will give more details later. Then you have the adaptation phase, which also have lots in common comparing to guideline development de novo. But the difference is that you start with looking for guidelines and not looking for systematic reviews or other original papers. And then the finalization phase also has a lot in common with guideline development de novo. And here you can see a different presentation of the 3 phases. And we developed 9 modules, including 24 tools to help guideline adapters to develop the guideline. And I will show you now more in detail the different phases and the different modules. You can also read it in the ADAPTE manual and research toolkit, but for others who are not so familiar with it, I will explain it. So here you have the setup phase, the preparation module. And I put in red the most important things to my perception, so that you do not read the complete slide. So you start with establishing organizing committee. So that's important. You still need people who look at the guidelines, who assess the guidelines, and who also have awareness of the context, who are also clinicians if you want to develop a clinical guideline. And ideally also have patients in your committee. Exactly the same if you're comparing when you develop guidelines from scratch. Then you need to check whether adaptation is feasible. You should have guidelines on your topic. If there is no guideline on your topic, you can stop. So it should be a topic where you have guidelines. You need to be aware of at least 1 or 2 guidelines available. So then you start up with the protocol, you define the task, and you make arrangement about the task, who is doing what. And that's the complete preparation phase. And then you have the adaptation phase, the real work of developing a guideline. Well, similar when you start developing a guideline or a systematic review, you start with defining the health question. And when you develop a search, a systematic search, then you all know the PICO, the patient intervention, control, and outcome. But the PIPO is typical for guideline adaptation. I will show you. This is the PIPO, which is with 2 elements which are different. So you need to define your patient population and the characteristics of the disease condition. You need to define your interventions, similar as when you start a systematic review. But the third is the professionals. Instead of the control group, you need to define your professionals. Who is the target group of your guideline? Very important to be aware of. Is it primary care? Is it secondary care? Is it public health? Very important. Then the outcomes is still the same compared with the systematic review or guideline development de novo. And the last point is also very important. What's your healthcare setting? Is it national? Is it local? Is it regional? Is it a healthcare system with a strong distinguishing primary and secondary care with the general practitioner or family physicians as gatekeeper, for instance? So you also need to define that. What's your setting and what's your context? And even in one country, it can be very different from the one and the other region or province. And then you start searching for the guidelines. There are different ways to do that. And I think nowadays, the most important source is the GIN database for guidelines. We also used to use the guideline library from the US, but that still does not exist. So the GIN database is very fine to start with if you search for guidelines, if you are a member of GIN. And then on the most topics, you have a lot of guidelines. So it is not feasible to do the guideline adaptation if you really want to save time and resources if you have more than 10 guidelines. I would reduce the total number to at least 4 or 5 guidelines of which you think they have high quality. And you can use the AGREE instrument, not the complete AGREE instrument, but for instance, the development domain to help you with reducing the total number. Because otherwise, it's too much work. It's not like a systematic review. You want to have good guidelines, and if you have 4 or 5 good guidelines, and even it can be 1 or 2, then you can start the adaptation phase in practice. Well, the AGREE instrument, I assume that you know AGREE instrument and AGREE 2, which was published in 2010 with a 7-point Likert scale, and again 23 items and 6 domains. I will not go in detail on that, but that can help you to assess the quality, which is the first step of assessing the guidelines. Because if you have the guidelines selected, then you assess the quality with the agree instrument, the currency, the content, the clinical content, which can be quite complicated, but particularly if you have a large guideline with maybe 100 recommendations. So you need also be selective on that, and you select only those recommendations who fit in your health question. There should be a match. And within the adaptation resource toolkits, we have tools to help you with that. You also assess the consistency, and consistency can also be checked with the grade approach. And that was not included in the original ADAPTE manual, but well, can also be used for this. And all the software available with grade can be used for assessing the consistency. And then you also assess the acceptability and the applicability. And I would say all these 5 elements of guidelines are all important. It should be sufficient or high quality. It should be current, because if it is out of date, you can use it. The content should fit with your question. It should be consistent, consistency between evidence and the recommendation. And the guidelines should also be acceptable and applicable in your country. 5 very important elements when you do the guideline adaptation. And then you need to decide which parts of the guidelines you accept or which parts of the guidelines you decline. And that you do with your panel. Then you need your panel with clinician, methodologist, and that's really a discussion which can be similar when you discuss the literature in an original guideline. And then you have, well, different options of decisions. You can reject the whole guideline because of quality or that it doesn't fit within the context on several reasons. You can accept the whole guideline, so it's okay, we keep it and we think it's fine. You can accept only the evidence summary and you develop your own recommendation. That's also an option which is often used. And you can accept specific recommendations and reject some other recommendations. And you can also modify specific recommendations in different balance. And then you prepare the document. And what is very important, because, well, if you want a high quality adapting guideline, you can also be very selective in all the phases. But if you explain it, what you do in that way that it is reproducible, that other people can understand what you do, that's with every research project. If you explain the process and explain the decision, which can be arbitrary, then we think it's fine. So that is very important. If you want to have a high quality adapted guideline, be transparent about the process and about your decisions. And then you start with you end up with the finalization phase, which is similar with developing guidelines de novo, external review by the target users and by maybe others and experts. And then you have the endorsement procedure, approval by endorsing bodies, also depending on the context who that are. And don't forget to acknowledge the source document. So the developer of the guideline you use for adaptation, you need to acknowledge them. And if it is a member of GIN, which is very likely, GIN can also help you contacting the original guideline developer. And then you should also have an aftercare planning. So, when after how many years do you want to update the guideline, and how will you do that? And finally, you produce the guideline and you publish it. So that is all the steps in this in the ADAPTE manual, which we described and explained. Well, and a few years ago, we had a guideline adaptation working group meeting, and we asked people to present examples of using ADAPTE in different contexts. And well, it is not complete and maybe a little out of date, but you can see many countries all over the world used ADAPTE in different contexts. And I will show you whether they are happy with that, with presenting the results of the survey. But well, it was really a movement that people decided to adapt guidelines instead of developing de novo, and maybe also a mix of that. I forgot to ask you, or I cannot ask you, I cannot see you, but maybe people will question why ADAPTE has an E at the end, because, well, ADAPTE is English, and yeah, ADAPTE is French. So that was also a discussion when we mixed the two groups to keep the E, and that's why ADAPTE is ADAPTE and not ADAPT. I would like to thank the English-speaking people from Canada that they were very well happy also to keep the E. Thank you. Then in 2010, well, there was a reason to transfer ADAPTE to GIN because the funding stopped. So we could work a few years on the ADAPTE manual and the research toolkit, presented at different annual meetings of GIN. So we could promote the ADAPTE manual, but then the funding ends, and well, we had the GIN Adaptation Working Group, which was established in 2010, but we also transferred all the documents and the manual and the research toolkit to GIN, and we asked the Adaptation Working Group to keep an eye on that and to evolve the methods and to maybe refine the toolkit if possible, and to also provide support and training to the groups. And they did. Every year they organized a working group meeting, asking about their experience and try to help developing the tool and the tools. So far, well, it's now 36 after 8 Central Europe time. So other questions so far? And yes, sir, if I look at the chat, I think I can continue, or do you think there are very important questions at the moment?
No, we haven't received anything in the questions and answer box.
Yeah.
And there's no questions in the chat too.
Okay. So then I continue. We still have 47 participants. Thank you for joining, and I hope you like this webinar. I continue.
Okay, we have one question, Jaco, coming on.
Okay, one question.
What are the recent upcoming projects for the ADAPT working group?
Yeah, I think that's a good question. But actually, the ADAPT working group does not exist anymore. We have the GIN Adaptation Working Group. And if you mean that, I'm one of the members, but I'm not the chair of the Guideline Adaptation Working Group. So I hope that the chair or the vice chair or someone else of the Adaptation Working Group is here, and he or she could answer the question in the chat. But they are active. Every year they have good well-attended meetings. And Jasse, you know, so it is still really active. The survey, we did the first survey in 2015 among all the GIN members, and we got a response of 84 people. I think that's good. That's good. If people are all over the world, I think you get a nice impression of what happened. So we asked them, are you aware of the process of guideline adaptation as a method? Well, almost all of them are. Do you know about the ADAPTE manual? 3/4, 75% was aware of the manual. So I think our promotion was pretty well. Then we asked, which approach do you use? So remember these two different forms of guideline adaptation, from national to local, and from another context to your context. And then you see most of them use several guidelines from other countries for national adaptation. And then second and third, they use several guidelines from other countries to your country, or from national to local. That are the most prevalent approaches. Then have you used the ADAPTE manual toolkits? Well, pretty good. Almost 2/3 did use the ADAPTE manual, and some even 5 or more times. Did you use also an adapted version of the ADAPTE manual? And well, also, well, let's say 35–40%. And we never say that you must use the ADAPTE process. It's to help you. It's help to inspire you. So we also, at every guideline working group meeting, we also said, if you want to adapt the ADAPTE process, it's fine. If it helps you, because it was a huge work to develop the manual, and we were aware that it could be improved. And also remember that the Great Working Group was also very active in those years, and that was not included in the first version of the ADAPTE manual. So if people and other groups were active and would like to refine the ADAPTE process, it's fine. So you see that that's also happened in 2015. Then do you use an altogether different guideline adaptation method? Well, you see almost 1/3 used a different guideline adaptation method, but they do use an adaptation method. So I think it's still fine. And what are the benefits? So we still would like to test if it is really saving your time and cost. Well, 62% said it decreased time, 56% said it also decreased cost, and that percentages also increased if you compare it to 2010. I think that was a good development. I think also there's also a learning curve, so people were more familiar with the method, also with more familiar with guideline development at all. So that helped to increase the efficiency. It also increased the transparency. What I say, if you are transparent on the process, independent whether you develop guidelines de novo or adapt the guideline, that's a good case. And you see the transparency, the reporting of the process also improved, but it can be better. Yeah. Then the barriers and limitations. Well, in 2015, I hope that it's now less often the case, but in 2015, 50% of the responders said, well, the low quality of the available guidelines was a problem. And that also depends how many guidelines you select in the first stage of defining and determining the guidelines you would like to adapt. And 57% still think that the guideline adaptation process, and if you follow all the steps of the adaptive approach, can be quite complex. And I've also heard that when I gave workshops all around the world, and even particularly if you have no experience with guideline development, and you think, oh, we adapt the guideline, that's easy. That's then you think, oh, it's still more complex than I would expect when I did not know that. So the complexity can still be a barrier, a limitation, if you have no experience in guideline development. And did you experience a learning curve? Well, yes, half of them said, well, we learned, and a quarter of that said, well, I still think that the benefits are still limited. So there was still work to do. Then in 2000, overall, you see 64% were satisfied with the adaptive process. So we think we still did a good job to develop the manual and to help people with the guideline adaptation method by the adaptive approach. And then in 2019, we repeated the survey, but not with the same questions, but with another aim, asking whether people think that the adaptive manual and research toolkit should be updated or refreshed. But here you see 55 responders. Most of them had experience in developing guidelines, and 2/3 in adapting guidelines, and still the same percentage as in 2015 used the adaptive manual, a bit more than half. And then we asked these questions, and I only present the most relevant steps for which the questions are applicable. You see the people tool, only 50% said that you need to update it. Other 50% said it's fine. But the agreed guideline quality tools, the guideline currency tools, the guideline content tools, almost 60% or more think that it should be updated or changed by different tools. And I can understand that because, well, these tools were pretty old and can be improved. And the last step, external review, 45%. So it's well, it's relevant, significant, but also work to do. And so that's about the ADAPTE manual and research toolkit. And I know that within the guideline working group of GIN, there were also initiatives to start with updating the guidelines, but there is really a problem. It's a lot of work. It's a lot of work. And if you do not have funding and you should only do it in your own time, well, it's difficult to realize this. So that's why there is no second version of the ADAPTE manual so far. Maybe there are other initiatives ongoing now, but so far we did not succeed in developing a second version as we did with Agree 2, depending on the funding. But the guideline adaptation methods and approach of ADAPTE, I think we can still say it causes a movement of thinking about guideline adaptation, a movement of thinking about the method of guideline development and using existing guidelines as much as possible without losing quality. And people think about using ADAPTE, but also think about using other adaptation methods. And the first one maybe is not so known. And you see on the bottom of the page the publication of Yang Song, and she and her colleagues reviewed all the different adaptation methods, and Can Implement was not included in that. No problem, it still exists, and Can Implement is still available in Canada and focusing on implementation. But including in the method is also using guidelines from another setting. So I think it's still a guideline adaptation method. But the use of magic software also using grade, making grade the irresistible choice. And that can also be used within some steps of guideline adaptation. And that first publication was in 2014. Then we have an initiative from Australia, 2016, a publication of Janine Lison and colleagues, an initiative in India, also a publication in 2017. If you want to look at these publications, go to the paper of Yang Song. They are also listed in the literature review list. I think they are very relevant to look at that. And maybe Yasser, other webinars in this series will tell more in detail about these new adaptation methods. So you can also see two methods of the United States, another method or approach within Cancer Care Ontario. The Delby from Germany is a method, and Dynamet also produced a method in the United States in 2019. So, and the last new paper on guideline adaptation has recently been published in the Annals of Internal Medicine, again with Yang Song as first author and Pablo Alonso as second author, also a very important member of the Great Working Group. You see also Holger Schünemann, a very nice international publication with a reporting tool for adapted guidelines. There is an Agree tool for developed guidelines, the Novo, but now you also have a tool for how do you report about the process of adaptation of guidelines. So this is also a paper you can study with lots of interesting literature references. To conclude, this is my final slide, Yasser. You can also develop guidelines for guideline adaptation. Yeah, that's in the bottom of my, well, to develop guidelines also for guideline adaptation. You need to use a systematic approach. That is very important to ensure high quality and not to lose quality. That's one. You should report it in a transparent and explicit manner so that other people can also do it again. It should be reproducible. And you should provide enough detail, yeah, to help it reproducible. And finally, you may adapt it. You may also use shortcuts or reduce the number of guidelines, for instance, or use not the whole Agree estimate, but only one or two domains. It's fine, but if you report, only if you report it adequately. That is important, because guideline development, you can spend years for developing the guideline, a very high quality guideline. but then it can be out of dated. Well, it cannot be used. You still need to be efficient, and the shortcuts are also important when you develop guidelines de novo, but also in the adaptation process. It's fine, but you need to report it. So that is my final message for you, all of you, and I would like to thank you very much.
Jaco, we have one question from Haskell. So it says, when I work for guidelines.gov, I think he or she was referring to the National Guideline Clearinghouse that was with ARC before. So he says, we encouraged guideline developers to use ADAPT. However, there was some reluctance to do this. I think the guideline developers were not keen to use research they had not performed. Have you encountered this reluctance?
Yes, I have encountered this, because you need to rely on the literature reviews, for instance. And but if the literature reviews and the searches have been reported very transparent, and the selection of the literature has been reported transparent, just like you do it in a systematic review, and then, well, you get familiar with the process, and you can also redo it, and you can also run the search again for the last month or the last years. So then you could do it again, but all depends on the reporting within the guideline you would like to adapt.
Okay, that's great, Jaco. Do we have any more questions? Feel free to type anywhere in the chat box or in the Q&A, no problem.
So maybe, Yasser, do you know the recent initiatives and projects within the Guideline Adaptation Working Group? I think that people also would like to know that. Okay.
Currently, the Adaptation Working Group, I'm the current chair, I'm Yasser Amir, and the vice chair is Ayn Soon. Recently we've launched, this is the first episode of the Guideline Adaptation Methodology webinar series. So we'll be going through most of the formal adaptation methodologies that Jaco just showed us in this last slide number 47. In addition, Pablo and Yang are working on a project for formulating GIN standards for adaptation of guidelines, similar to what was done before by the GIN when they published in 2012 a set of standards for de novo development of guidelines. So now we're going to work on a set of standards for adapting or adaptation of guidelines. In addition, we're going to hopefully move forward with testing of these different methodologies in different settings, or I mean, study the like the practical tips and tricks of what are the requirements or the constraints in different contexts or in different healthcare settings for each one of these different adaptation methodologies.
Yeah. Okay, Yasser. I see also questions in the Q&A. So I would suggest to answer these questions. Okay, I also see that other participants answer these questions, but I see that Jopetra said, well, one of the problems we encountered was indeed the low quality of available guidelines. And how do you handle the situation when, for instance, no clinical questions were used, or potential conflicts of interest in the original guidelines were not handled adequately? In that case, trying to adapt guidelines to actually mean more work instead of less work. Any ideas on solutions? Yeah, that's a good question. I think there should be basic quality of the guidelines. If you see that the reporting is very few and there are no clinical questions, you can identify no clinical questions, so you cannot also assess the matching of the clinical questions of the guideline with your guideline. I would say reject the guideline. You cannot use it. So there should be a minimum volume of information for guideline adaptation. And potential conflicts of interest can also be a problem, particularly when industry could come in. So you need also be aware of that. Yes. So I would say set a minimum level, and if there are no good quality guidelines available, I would not adapt. I would anyhow not adapt low quality of guidelines. So that would be my question. And then I see a question of Malavika Tampi, I guess from Finland.
Yeah, that's a good one.
Who should be the ones initiated adaptation or the adoption of guidelines? If there are settings that would benefit from exploring guideline adaptation, there is no team. How can guidelines be brought there? Well, I have examples that external parties, and I mean with external parties, that not professionals themselves or patient organizations ask for a guideline, but that the government from a country said, well, we have very high costs and we want a guideline. And then they ask, well, there are guidelines from other countries. Well, we can adopt them. And that is much more efficient than we set up a working group and an organization and methodologies and reviewers. We adapt the guideline. So I think also one of the basics, if you start or initiate a guideline adaptation, you want to involve the user of the guideline. And the use of the guidelines of clinical guidelines is healthcare professionals and also patients. That's sometimes difficult to involve them if you do not have a system or if you do not have patient organization. But at least healthcare professionals should be involved in developing guidelines. So if there is an external body initiating the adaptation, they should contact the guideline, or sorry, the professional society or other people representing the professionals. And then you can do it. But if you have no experience with guideline development, you have no methodologist on board, I think it's very difficult. It's not easy to do that. You should also have a minimum level of knowledge of guideline development. I see another question. Will there be a presentation on ADAPTE at the GIN meeting in Toronto? We have not planned because this is the first from a series. It's also a bit historical. And I hope that there are other webinars in this series explaining more about the new developments. So we have not planned a presentation yet on ADAPTE. But if there is interest from the organizers of Toronto, I'm happy to do that. So, but not yet, there are plans. Trudy Beckering from Belgium. Are you aware that NICE asks money if you ask to adapt their guidelines? This may also be a barrier to use ADAPTE. And could GIN play a role? Well, I know in the Netherlands, we often use the NICE guidelines, and they are, well, open on the internet, also including the appendices. But maybe that has changed, so I'm not aware of that. And
yes,
it has changed, no?
It has changed. Now there is an international end user license agreement that you have to sign if you will use any product from NICE outside England and Wales.
Yeah,
I've experienced this myself. It's a big barrier.
I think, well, maybe it's political what I'm saying. I think the Brexit has to do with this. And I can also understand this because lots of effort, lots of money are paid from the National Health Service to NICE to develop guidelines. Hundreds of pounds, thousands of pounds are the cost of a guideline. So, well, I can imagine that they now would like to ask some money for return. But well, the NICE guidelines have very high quality, are very transparent on the questions, on the literature search, on the selection, on the recommendations, on the how the evidence has been translated to recommendations. So, well, that will complicate guideline adaptation. Sorry for that. Yeah, and I hope that people from NICE can still do something to the members of GIN, because GIN is a network and can bring people together. So I hope that we can help them. Yang Song, to adapt guidelines, guideline developers might need to have the expertise in both the de novo and adaptation processes. What's your opinion on the complexity of the adaptation process based on your experience with implementation? Do you think that the adaptation process could reach the goal to save time and resources? I I think you should have a basic level of knowledge and experience in guideline development. I think you should also have a structure with a guideline organization, with methodologies, with good representatives of professional organizations, of patient organizations. If you do not have this, and that's also all important for the preparation phase, it is very complex to start with guideline adaptation. You need to have structure. You need to have some basic resources. And well, it depends per country, but well, guideline development is expensive. In our country, we cannot make a guideline with less than 100,000 euros, which is 120,000 US dollars, for instance. So you need to have basic resources. And I hope that within our network, we can also help the middle and low income countries who are a member of GIN. But well, there should be a basic level. And if you don't have this, then it is still complex, Yang Song. And well, and implementation can also be very difficult if you do not have your target users on board. So I think that were the questions in the Q&A. And
I think we have one more, Jaco, in the chat. So does the ADAPT tool recommend regular review of guidelines, expiry dates of guidelines, review of correct implementation of the guidelines in the clinical field?
About the currency of the guidelines, well, there's a basic rule, but it depends on the clinical topic. Some clinical topics are very rapidly evolving with new research and new developments, particular topics with drugs, a lot of drug recommendations. But a basic rule is that you need to look at the currency of the guidelines after 5 years. And that's the average. And some guidelines you need to look every year or every 2 years, for instance, on diabetes or hypertension. There's lots of developments, but other guidelines on skin problems or ear problems, you can wait for longer. So that's a basic rule, which I remember there was also in the ADAPTE tool. And the review of correct implementation, it's not in the ADAPTE research toolkit. It's the tool for development, but within the development, you need to every time be aware about the implementation, about the acceptability, about the applicability. So there is still a strong focus on implementation. You can develop a very high quality guideline, but it is not used in practice, if it cannot be implemented, if you do not correctly adapt the recommendations from the context of the original guideline to your context, and it cannot be applied, then it will not work. So it's very good that if you have an adapted guideline to also look at the use in your own context, because otherwise all the efforts are spent without any success.
Jaco, actually, I have a question myself about this permission, because usually this is a debate among the groups. So NICE is a good example, but I mean, even similar organizations, if they refuse to give their permission to adapt and your project does not have a fund, so do you simply take a decision and describe it in the adaptation process that you will exclude this guideline because you did not receive any permission to adapt it? Or you will say, no, I will acknowledge them clearly in the adapted guideline and say, I adapted my guideline from them. So actually, I don't need any permission, especially if they are an open source. The guideline is available and accessible. What do you think?
I did not take the question. Is it in the chat or in the Q&A?
No. This is from me.
Oh, sorry. I was looking for the text. Could you summarize your question, Jaco? Sorry.
Okay. About the permission, like NICE is a good example.
Yeah.
Any organization will not provide you permission to adapt to their guidelines. So will you simply exclude their guideline and write it this way in the report? Or you will say that you acknowledge them clearly and you will frankly report that you adapted from their resource. What do you think?
Yeah, I think you cannot adapt the guideline if you do not get permission. And I hope the guidelines is a product of research. and we think that should be in the open public context. But well, on the other hand, I can understand, and I hope that, well, you can also, well, I'm not nice, so you can always negotiate and try to think, well, this is our problem, can you help me? And within GIN and all the members of GIN is a network, and you can ask things among the members. So NICE is also a member of GIN. You can still try and ask, can you help us? And but well, you need to get permission, and and sometimes, well, what I would recommend NICE is to have a cut. This is public and this is not public. So some tools, for instance, the literature search, which is a lot of work to do that. We keep that for ourselves, and you can pay for it. But for instance, the recommendations, or maybe the information for the public, for the patients, which is also very expensive to do that well, that could be in the public domain. But well, maybe it's good for GIN, for the GIN board, to arrange something and to ask NICE to how can you help the international community with guideline development, as you did before. I think that's a very important issue. A task for the adaptation group, maybe.
Yes, that's an excellent suggestion.
Yeah.
You know, the same initiative that GIN itself made when it opened the library, the international library, used to be by subscription. Now it's open since COVID.
Yeah.
Okay, okay, Jaco, there's another question here. Do you mind repeating the estimated cost of developing a guideline? I'm not sure if this person is asking about developing or adapting.
Or maybe to remit, well, it depends per country. In the Netherlands, we cannot develop a guideline with below 100,000 euros, which is $120,000 US dollar, 80,000 pounds, like this. Yeah, but there are countries which use double, and there are also countries. I'm not sure. I see Lane, you are here from Belgium. Well, they are very efficient. They have less resources than in the Netherlands. So I know that they use the adaptation process very often, and they can adapt guidelines with lower costs. But I will not mention the amount. So some countries are very efficient. But I can also say that our Flemish French have a lot of experience with guideline development. So they know the shortcuts and they know how to report it. They also have good professional organizations who are familiar with guidelines. So they have a structure. And if you have a good structure, you can save money.
We have a comment here from Teresa. However, from our experience, most of the guideline developing groups are happy their baby is wanted somewhere else, and they do provide their consent for adaptation.
Yeah. I'm not completely understanding the questions. Are they reluctant to use their guidelines from in another context?
No, this one was a comment. It was not a question.
Oh, it's not a question, because yes, if another country, well, I think she means the reverse. So if other countries are interested in your guidelines, then well, okay, you can use them. Well, let's say I can tell you some experience from the Netherlands, from the Dutch College of General Practitioners. We have a large guideline program since the late 80s, last century, and more than 100 guidelines. And there were countries in South America interested in our guidelines, from the Portuguese and the Spanish language, and they would like to use them. And we said, okay, you can translate them, but you should publish them in the public domain. So we were happy with our babies, and we were also happy with translation and use in other countries. And maybe they also adapted the guidelines, but well, we are open for this. Guidelines in the Netherlands are in the open domain, and I hope in many countries that is still the same. I see that Sign, for example, is also very supportive. The Sign is from Scotland.
Yes.
So we all know that that's almost the oldest guideline organization in the world, I think. They started also in the 80s, I think. And very nice website. So you can look at nice guidelines, but also at Sign guidelines.
Yeah.
Where
The
you
same quality, the same methodology almost.
Yeah, yeah, and say, well, it's yeah, yeah, good guidelines. Anyhow,
Yeah.
yeah.
We have a comment from Lynn here. I have to submit a guideline pretty soon, developed with a budget of 78,000 euros,
Yeah.
but most of the time was leisure time.
Yeah, thank you, Lane. Thank you very much for sharing this. Yeah, yeah, yeah. And well, independent whether you adapt a guideline or develop a guideline, well, guideline development can be very complex. Also, the human part with discussing with other peoples with different interests. And I'm not only talking about commercial interest or industry interest, also intellectual interest deal. So you also have this with adaptation of guidelines. So lots of complexities also exist when you develop guidelines without adaptation. And yeah, you will see that if you do it. And well, I'm so happy with Jin, Yasser, because if we meet, if we have conversations, we share those experiences, we share the problems, and we can learn and we can help each other to tackle the problems. And sometimes problems are really complex and still needs to exist.
We have one question from Ilda. Sometimes we struggle with guidelines with low amount of evidence and lots of expert opinion. Does ADAPT help with that?
No, I think it, I think not. I think GRADE can help. The GRADE method can help because they acknowledge the level of evidence, but they also have a structure, a systematic approach from translating the evidence to the decision or to the recommendation. That is the ETD, Evidence to Decision Framework. Look at the publications of Pablo Alonso and in the Journal of Clinical Epidemiology, a very nice series. And then you see how you deal with low evidence, but you can still develop or formulate a recommendation. And there are also studies which assess the level of evidence among a group of recommendations on certain topics. And level 1, the randomized clinical trial evidence, will only exist in maybe 10 or 20, at highest on 20% of the recommendations. Most of the recommendations is expert opinion, but you can still have a high quality guideline based on expert opinion.
Okay, do we have any more questions from the attendees?
I don't see any questions now in the chat.
No.
I stop sharing my screen now. And now I think we both are to see for the audience. What's the time? I think we had 1 hour, Yasser.
Yes, yes.
So it's now 30 minutes after 9 Central Europe time. So I think we can still wait for a last final question, or I hope you liked this webinar. Thank you so much for your presentation. Thank you, Michelle. That's very welcome. And we can also learn from this webinar. I think, Yasser, to evaluate this webinar, we should do a rehearsal for the techniques the next time. So sorry for that.
The slides will not do the player mode.
Yeah, we had problems with the presentation, and so it took 10 to 15 minutes to start. And okay, well, thank you.
What is the schedule for future webinars?
Yeah, that's a good question. That's for you.
A good question. Yes, yeah. I have preliminary approvals from key authors of Magic, GRADE. Can implement. I could not find anybody who was interested to present. Who else? Adapted Adapt we have. K2 modified Adapt we have. Yeah, these are the ones that responded so far. and also RapAdapt. RapAdapt will, so we have, but the schedules have not been, finalized yet. So once they're finalized, they'll be posted to the Connect platform of GIN.
Yeah. Okay. I think we can say goodbye, Yasser. Thank you very much for organizing.
Thank you, Aki, for this wonderful
I'd
presentation.
also like to thank Alice and Jenna for on the background. And then, well, hope to see you in Toronto. All of you.
Thank you so much.
Bye-bye.
Thank you, Aki.